Yes, Dr. George W. Vetrovec joins us from the VCU Pauley Heart Center at Virginia Commonwealth University. Dr. Vetrovec's scholarly interests involve improving the management of coronary artery disease, particularly related to catheterization and interventional techniques. He has had ongoing funding for clinical trials for over 25 years. He has authored or co-authored over 200 papers, 8 book chapters, and has edited 2 texts on interventional cardiology. And he also serves on multiple cardiovascular journal editorial boards. His topic today is robotic-assisted PCI, opportunities for improved precision and efficiency. So please help us welcome Dr. Vetrovec. Thank you so much for being here.
I hope over the next few minutes to excite you a little bit about the fact that we really can potentially do angioplasty better by using robotic technology, and to introduce to you at least what's known about this at this time. So I'm going to talk about robotic-assisted PCI, opportunities for improved precision and efficacy. These are my disclosures, and my only disclosure related to this is having had a grant for studying the product. So why robotics? We're going to talk a little bit about that along with the systems, look at some case examples, some opportunities, and then a few questions that come up. Well, first let's talk about what we're talking about in terms of why consider robotics. Well, first of all, from an operator standpoint, it's long been postulated and I think recognized that among interventional cardiologists there is a significant risk of orthopedic risk, particularly back and neck. There's certainly personalized radiation exposure, which is substantial for operators, and then anything that we might be able to do to reduce time or improve efficiency would certainly always be welcomed by interventional cardiologists. In terms of the patient side of this, I think there are a number of opportunities in terms of improving the procedure that should lead to better patient outcomes. Better visualization for the operator, as I'll show you, for anatomy, branches, lesion composition, boundaries of lesions. The whole issue of geographic miss. It's estimated that about 15% of patients get an additional stent during the procedure, oftentimes or most times because of inadequate placement or sizing of the first stent. And that's the reason that there's a U.S. average of 1.21 stents per lesion as opposed to per case. Contrast use is a problem if we could eliminate that, and obviously if we could reduce patient radiation. This is just more information about geographic miss, and the only point I'd really like to emphasize here is it has been reported to be very common, and in particular, if it occurs, it is associated with worse outcomes, about 3 times the incidence or an increased incidence of adverse outcomes. So this becomes an important issue in terms of determining the appropriate link for stent therapy. And then finally, just in terms of overall outcome, better patient outcome, it's clearly the right thing. And then from the perspective of the interventionalist, I think those of us who do this really believe that in appropriately selected patients, we make a difference in managing their angina. And we continue to be under fire because of concerns about, does angioplasty really improve outcome, even symptomatic outcome? And we're aware that in the COURAGE trial that up to 3 years there was a symptomatic benefit, but by 5 years it was lost. And a recent meta-analysis published in February of this year in Archives of Internal Medicine, using trials that had at least 50% stent use, there were a number of variations in terms of outcome. But when you look at the final, there was no symptomatic benefit, but it's really very close. And so one can say that perhaps with a little bit better tweaking of interventional procedures, we could move that bar perhaps where we all believe it really should be, and this might make it the preferred symptomatic treatment for patients with angina. What about the system? This is the system demonstrating here the operator sitting in a console which is lead shielded, and a device holding on the side of the table, which is what is the driver for delivering the guide wires, balloons, and stents. This is all controlled remotely from this site. This is what the operator is actually looking at. Hemodynamic monitors, very close-up visualization of the fluoro images, and the ability to sit comfortably even in a long case while they're doing this. They have the ability to fixate the wire, advance the wire, retract the wire, rotate the wire, and even do measurement, not visual length measurement, but the actual course that the wire took that distance to better size the length of a stent. So this is the actual guide wire being placed into the driver here. You see the hatch is being closed, and it's now ready for operation. Very simple system to utilize. This is just an example of the ability in a tortuous vessel to effectively measure the actual length of that by marking the point where the wire starts and where it ends in terms of the lesion length. And even tortuous vessels, you get a true length measurement. This has the ability to advance the balloon and devices very slowly, even 1 millimeter at a time, and it's excellent for really getting that exact spot where you want to overlap a stent just perfectly. So it really has the ability to improve precision. The ability to lock the wire obviously allows bifurcation lesions where the devices often interrelate and move each other to help fixate those so you get better potential positioning. And then this ability to steer into bifurcation lesions. This is an example. You see the steering on your left and the wire being brought down with die test here to get into the appropriate branch. And you see the ability to turn this wire all robotically, not standing at the table side. And this finally is a bifurcation through a stent, which is quite possible to do with this system. So a couple of things. You say, well, gee, something complicated like that. How easy is it really to use? Well, it's easy installation. It requires no construction. It requires only a short physician learning curve. I'll come back to that at the end. Time efficiency. It's easy to load the cassette. Rapid navigation, quick, accurate measurement. So it's a very efficient system. And it also has open architecture, so it works with any device that you want to use, whatever balloon product or wire product you're used to using. In terms of potential benefits, there are many. Enhanced visualization, as I've shown you, a relaxed, comfortable operator, accurate measurement, precise positioning, 1 millimeter movements, guide wire fixation, reduced case time, reduced radiation, patient and operator both potentially benefiting, and lower contrast use. So let's look at a couple of examples of these. All come from our laboratory here. A very eccentric, severe right coronary artery lesion. This is with the guide wire across it, and you see the balloon being driven down by the robotic system, sort of the look ma no hands technique. This is the final result with an excellent result. And now that was a right coronary. I'll show you all the vessels. This is a anterior descending with a tight mid lesion. Very complicated anatomy from a steering standpoint. You have to stay out of this branch, stay out of a huge diagonal, and steer into the LAD. We were able to do this robotically, and you see the guide wire now in there, and you can see actually the bias on that wire, so that it was a tricky potential steering circumstance. And this is after we've successfully stented it. This is the circumflex, just to show you that we can successfully do that. And this is a right coronary artery that's relatively tortuous, and we successfully did that. What about some early results? Certainly it technically works. What do we know about it? Well, the first was a trial in animals comparing manual to the robotically driven system and to look at safety, efficacy, and any injury to the arteries, and compared procedure time, contrast use, and the like. And what you can see is compared to manual time, the CorePath system had a lower procedure time, less x-ray time, less contrast utilization, and overall lower operator radiation. Likewise, there was no injury to the vessels from the system, and so it looked like, from an animal study, comparing the two techniques to be safe and potentially effective. Subsequently, there's the first in man trial, which was done with Dr. Granata and Dr. Georgi Weiss in South America. And you see in that study there was 100% success in 8 patients, 97% reduction in physician radiation exposure, 35% reduction in contrast, and comparable fluoro time. The last trial that's been completed, and the data will be presented later at this meeting, is the CorePath Precise trial, which was an FDA trial to support a 510(k) submission, multi-center across the United States with 164 patients in 9 clinical sites. Now, I cannot tell the data from the entire study, but the data from our site showed we did 10 patients, 100% success without conversion to manual, no crossover, no MACE. So what about the opportunities? What does this provide in terms of future benefits? Well, from an operator standpoint, minimal radiation, less orthopedic risk, improved visibility sitting in front of it, and reduced fatigue. I would suggest that you look here at the operator leaning over the patient, trying to see the image on the screen at some distance, working on his back. And here's an operator sitting comfortably, able to look at very close up and do his or her steering. So it has real potential advantages. From a patient standpoint, lower radiation exposure, hopefully, reduced contrast use seems to be reproducible, and more precise stent placement. From a laboratory standpoint, this could lead to more rapid turnover, reduced stents per case, leading to cost savings and improved outcome measures, particularly if you look at radiation dosages and so forth. So I think it has opportunities to help each person in the circumstance. Now let's end by talking about a few frequently asked questions. The first is, when will the system be available? Well, it's up to the FDA. The pivotal trial is completed, and obviously we hope this will be available soon because we think it has something to add. What about tactile sensation? This was a real concern in my mind starting this up. After all, I've been twirling a wire for 30 years, and I've come to the realization doing this that there's a significant visual component of what we think of as tactile sensation. And if you think that I'm not real, think about those of us who train fellows. We stand next to them and know when they have a problem visually without ever touching the wire. And I think this system really illustrates that opportunity. And then what about staff radiation? Doctor sitting in a safe little cocoon, what happens to the staff? Well, there's every opportunity for the staff to be protected and back, because this has all been being done by the operator, particularly if you use a hand injection technology from the site that you're doing the steering. So there's really no need for any personnel to be right next to the patient at that time. Now, what's the learning curve? I really think it's minimal. It can be done with either simulation training or 1 or 2 cases with some supervision. Even for a senior operator like myself with no video game experience, and my grandchildren can do all those things. I was able to learn this very rapidly, and I think this has really across the spectrum ability to be easily introduced. It's really neat. It's got the 1 millimeter by 1 millimeter advancing, the steering back and forth for forward and back, and yes, it even has a turbo button so you can speed it up when you're bringing it back. So in summary then, what I've tried to describe to you that our experience with a robotic interventional system is that it's safe, effective, it's adaptable to existing practice by current operators, and it provides a new level of precision and efficacy in coronary intervention. Thank you very much.
Thank you so much for joining us, Dr. Vetrovec. And I think we do have time for a question or two. If anybody has a question for the doctor, we can take that. No? If you would prefer to, we do have one over here.
As someone who's building a new heart center, any idea on timeline, like 5 years out, 1 year out?
No, I would get, I mean, I don't know anything about the FDA and what the process is, but this is a 510K submission. The submission has gone to the FDA. I think they have 90 days to respond. They will certainly have questions. They'll be back and forth. But I would think that before the end of the year, this has a potential to be available.
And are there any spatial considerations in a room design for this?
Well, as you can see, it's a cocoon that sits in the lab. So an absolutely tiny lab where there's just no backspace, that would be a potential limitation. But most labs today are pretty spacious, so there's room to set this in there. It's not a large device.
Okay, thank you.
All right. Another question in the middle here. Here we go.
Thank you.
Sure.
Short question. Can I drive an IVUS or OCT catheter as well?
Well, there's just no experience with driving IVUS or OCT. And so I can't answer that, but it certainly would seem feasible potentially to me.
Can you, as the operator, skip the leading at all?
Yes, you don't have to wear lead. You saw me in one of the early pictures. I was actually scrubbed and gowned because I actually put the guide catheter into position myself and then went over, and you can leave the surface sterile so you can do all your work. And then if you have to go back and adjust the guide catheter, you want to take your final angiogram, you can do that. But you don't have to do that. If you have someone else to put the guide catheter in place, you can have no lead apron, just sit at this console.
Last question, cost of the system and appreciation in the cardiology community?
I don't know the cost. I'm not the business guy.
All right, fantastic. That's all the time we have for questions.
Okay.
How about another thank you for Dr. Vetrovec?
Thank you.